Ruth. I'm Clinical Nurse Specialist for Stroke Services here at beautiful RUH, and I want to do a quick tutorial for you called FASTVAN in 5. Canadian Stroke Best Practice recommends we use a consistent stroke screening tool for all suspected stroke patients. In Saskatchewan, the first part of our stroke assessment is the FAST assessment. FAST was developed by the Heart and Stroke Foundation. Facial droop, arm weakness, speech slurred or jumbled, and T for time to call 911 or time the patient was last seen normal. So FAST is a great general stroke assessment that will identify a stroke occurring in the anterior circulation, anterior being areas of the brain supplied by the carotid artery. It could be a small vessel disease stroke or a large vessel disease stroke. If your patient has one or more FAST stroke symptoms, you move on to the VAN assessment. VAN starting with visual gaze preference. When you're assessing a patient for a visual gaze preference, your patient will have eyes directed at one side or the other. And the side that the eyes are directed to will be again away from the hemiparetic side. A is for aphasia. So it builds on the speech assessment and looks closer at an actual aphasia screen. When you're screening your patient for aphasia, you want them to name a high fluency or frequency word like glasses or pen. If they're unable to name, you would say they would have aphasia. N is for neglect. Neglect is a little bit trickier, but you're going to determine if your patient has neglect by dual tactile stimulation. So you will touch the left side of their body with their eyes closed and ask them to identify what side you're touching. You'll go on to touch the right side and ask them what side you are touching. And then you will do dual tactile stimulation, touching both sides of the body at the same time to see if they continue to recognize the left side of their body. So why is FASTVAN an important screening tool? Well, it really comes down to helping the assessor differentiate if the patient is having a small vessel occlusion or a large vessel occlusion. So a small vessel occlusion occurs when the smaller arteries of the brain become blocked and there's a lack of blood flow causing stroke symptoms. These small arteries becoming blocked are really amenable to TNK or TPA, which are clot-busting drugs. These clot-busting drugs can be given at any of Saskatchewan's 9 primary stroke centers, so any center that's CT enabled. When we move on to a patient being FASTVAN positive, we're really looking at patients who have large vessel occlusions. These types of strokes are amenable both to TNK or TPA if last seen normal was within 4.5 hours. But also they're amenable to endovascular therapy, which is when the surgeon goes in through the groin, up into the brain, grabs onto the clot, and pulls it out. Knowing if your patient is FASTVAN positive can really indicate which provincial stroke center the patient should go to. Saskatoon is the only center that offers endovascular therapy, so if your patient is outside that 4.5 hour window, it's really important to get them to Saskatoon as quickly as possible. I'd like to make a little caveat for intracerebral hemorrhage. So really, until we get that CT scan, we don't know if a patient has an intracerebral hemorrhage or a thrombotic stroke. Either way, the patient will present the same, but really need the CT scan to tell us what the diagnosis is. Let's go ahead and try a real-life FASTVAN stroke assessment. We're going to use a left middle cerebral artery stroke as an example. This type of patient will have deficits on the right. So if we start at F, they're going to have a right facial droop. They're going to have some kind of speech impairment because of that facial droop, and their right arm will drift, or it might even be flaccid. So they have FAST positive signs. Then we move on to the VAN. With these types of patients, their visual gaze preference will be towards the left. Stroke look away from their area of deficit. The left side of the brain is in charge of speech, so we would expect that these patients will be aphasic and unable to name. Patients who are left MCA strokes will not experience neglect. Okay, let's move on to a right MCA stroke syndrome. If we start with the FAST assessment, they will have a left facial droop. They will have arms where the left arm drifts or could be flaccid, and their speech may be slurred or jumbled because of that facial weakness. When we move on to the VAN part of the assessment, these patients will have a gaze preference towards their right and probably won't be able to cross midline. They will be able to speak. Language isn't affected because language is the job of the left side of the brain. They will have neglect. They won't attend to their left. They won't recognize their left. It might be as subtle as on dual tactile stimulation, they forget they have a left side, to as extreme as you show them their left hand and they don't recognize it at all. Okay, so I think that sums it up. Covered the FASTVAN in 5. Lots more stroke talk to come, so stay tuned, and I want you to save lives and improve functional outcome.